So we will get started with the medicine section. So the medicine section has, I don't want to say they're oddball codes because we went through each individual section, but these are like the non-invasive or the less invasive things that can be done. So we're going to have some psychiatry codes, biofeedback, dialysis, there's some gastro codes, ear, nose, and throat codes, cardiovascular, neuromuscular, wound codes, just to give you an idea. Your medicine codes are at the very end. Of course, they begin with the 90,000 codes, so you've got a little bit of your guidelines. And so medicine section 90281 to 99607, diagnostic and therapeutic that are generally non-invasive. And again, your non-invasive is not entering the body cavity, but there are and will be some invasive, which is entering the body cavity in this section. The cardiac cath codes, some of them are in this section. Again, it has the guidelines applicable to the medicine section codes, the add-ons, so nothing different than any other chapter that we've had. Again, stressing, making sure to read all notes pertaining to the group of codes that you're working with. So if you're working with the vaccines and toxoids, again, reading those notes to see if anything to us.
We're on.
There she is.
Hey.
Hey.
Bye. Okay, thank you, Caleb. Bye.
All right.
Sorry, we had the wrong IP address or something. So
Oh, that's okay.
Thank you.
No, fine.
Is that close enough for you?
Mm-hmm.
Okay.
Thank you.
It was literally just a different IP address.
I'm down the hall if you need me.
Yep, come back in the office. I'm in 127.
Thank you.
6 to 7.
Okay. Do you want to take my cell phone number down? And you can text me if something blows up. Okay.
Oh,
It's 7.
hopefully that doesn't happen.
Right? 3448. Okay. And just 207 in front of it. Okay. I'm just literally right around the corner. Okay. Thank you. You're welcome. That's yours.
What did you get caught up in last week? What was that accident? Did you ever hear?
Yeah, in Wyndham, it was just a one-car accident, like a 25-year-old girl with 3 passengers, and I was in traffic for like an hour. Luckily, I leave work at 4, so at 5 o'clock I thought, okay, well, I still have a half an hour, and then they came and told me it's going to be another hour before they can get everything out. So I had to turn around and go, I don't know if you know this town, but I had to go from Westbrook Wyndham line all the way back into in-town Westbrook by like this Rite Aid Rotary and all the way through. It took me almost an hour and a half to 2 hours to get home. I would have,
Wow.
If I would have come here, I wouldn't have been here till 7.
Wow, that's crazy.
Yeah, for one car involved, yeah.
Wow. All right. Well, we just started, so no big deal. We're doing the medicine chapter tonight and finishing with inpatient coding. We don't get all the way through the inpatient coding. It's okay because you'll see a lot of it is repetitive from what we've learned. And then, did you get your exam?
Yes.
Okay.
Yes.
So, okay, so what I was telling Christian I need to do is I need to have Amy or Jamie, so weird, check with the schools to see if class next Thursday is okay, or if we can wait till that last week, which puts us into March. The only thing I'm thinking is I think the new round of classes start the 1st of March, which if that's the case, there'll be other students in here using the Tandberg, so I wouldn't be able to do it. So I'll send them an email as soon as they let me know whether it's going to be next Thursday or the 1st. I'll send you guys an email, and then we'll wrap up anything we haven't finished in the textbook, and then we'll, now I don't go through this book front to cover, front to back. But what I want you to do is in there, I think it's chapter 30, Christian and I just found out, but the exam is chapter 30. I recommend, you don't have to rip it out of here, but if there's a way that you can copy it and make as many copies as you want, because when we're doing it in class, I don't do all the questions, like medical terminology questions. I'm not going to go through those. My focus is making sure you understand how to work through the coding ones. So I'll pick ones that will test you. I'll pick ones that'll be a little bit easier than others. But that last class, we will go through as many questions on that exam that are coding related that I can get through for you.
Okay.
I was not able to, I was not able to make it to the chapter meeting Tuesday night because we had 2 interviews at work, and I started at 7 in the morning and I got home at 7 at night. So I didn't go up to Lewiston for the meeting, but I did send your mom a message about if they got a chance to talk about the exam, the exam thing. So as soon as she gets back to me on that, I'll let you guys know as well. So
does your mom do the exam?
Huh?
I don't know. I don't
You don't
think
know?
so.
Oh.
No, what her mom's going to do is her mom is the president of the Lewiston chapter, so she's the one that's going to try to organize with Portland and Bangor to see if they will go in with the Lewiston chapter to sponsor a 5-hour prep day, which I teach, but I go in and kind of do the same thing I do with you guys, but we get a little bit more in depth with it. There's some flashcard type stuff we do, a lot of interaction type stuff, and we did it for the first time last August. I think I had over, I bet you it was 50 people that showed up. We had a really good turnout, and I got really good responses from the people. They were very glad they had that because it did help them to pass. There were still a couple that didn't pass, and their issue was time, which is usually the case for some people. They just don't realize how much time they're wasting on questions, rather than trying to keep moving and getting as many questions as you can, and then go back and try to do those. So hopefully we'll be able to do that, and I'm going to push for local. We did it at Maine Med last time, which worked out really good because we had a nice big room. Sometimes we can get the hospital up in Lewiston, so I'll keep you guys posted.
Okay.
So the medicine chapter again is non-invasive testing, which is not entering the body or a body cavity, and then some invasive. But it's kind of just a variety. There's some cardiology codes in here, chemo, gastro, your physical therapy codes are in here, chiropractic codes are in here, medical nutrition, so a variety of codes. So we'll go through what those codes are. Again, the codes start 90281 to 99607. A lot of specialized tests in the medicine section. So we've got biofeedback, hearing tests, EKGs. Codes in this section do not usually include supplies. So again, we report the supplies and or the drugs with either the appropriate HCPCS code or your supply code, the 99070 code. Again, that 99070 code, you will have to explain on your claim form what those are. And sometimes even that isn't enough for the insurance company because you're using a generic code, so you're really not giving them a lot of specifics. I could bill that 99070 code for a medication and put, a $400 charge on that medication. Well, what they're going to do is how do they know that that med really cost us that much money? They don't. So what they're probably going to do is they may pay the office visit that I billed with it, but that line for the medication is going to deny, and it's going to be sent back saying they need an invoice, meaning they want to see how much we paid for the medication. Because typically, they're not going to reimburse you much more than that. Your goal is not to make money on medications. So that 99070 code, that's, the purpose behind that one. Again, if you look on 671, contact lenses are another supply. So there we would have the HCPCS code possibly for the supply of contact lenses. It's for the supply of contact lenses may be reported as part of a service of fitting or reported separately. So again, somebody just comes in, pick up the contact lenses, great, but if they're being fit and supplied, then we would combine it. And again, reporting supply of lenses specifically depends on your third-party payer guidelines. Again, some may only pay for, X amount of contact lenses over a year's period of time. So if you're really bad and you lose them, then they're not going to continue to pay for you to get more. We have in the medicine section, if you look in your CPT book too, we have the introduction to immunizations. So there's two types of immunizations. There's active and passive. Active is when you are in anticipation that you're going to be in contact with the disease. You can be given toxoids or vaccines. The toxoids are bacteria that have been made non-toxic, and when they are injected into your body, they produce an immune response. Vaccines are viruses, again, given in small doses, that also cause an immune response. Your passive immunization does not cause an immune response, but the injected material has high level of antibodies against the disease. So the first three sections in your medicine section, again, you can see it in your CPT book, are the immune globulin serum or recumbent products, immunization administrations for vaccines and toxoids, and then the vaccines and toxoids themselves. So the immune globulins, 90281 to 90399, these are passive immunizations collected from human plasma. These identify only the immune globulin product. They must be reported with an administration code, and you can see in your textbook what those administration codes are. And again, if you read the little blurb above code 90281, you may want to highlight that it also tells you reported in addition to the administration code. When I've done audits before, I've seen the immune globulin codes, but they forgot to report the administration. So even if that administration was $50, that adds up after you've done so many. On page 672 in your textbook, the immune globulin subsections are based on the type of immune globulin, the method of injection, and the type of dose, meaning was it a full dose, a partial dose, a mini dose. So the immunization administration subsection codes 90460 to 90474 are reported in conjunction with the vaccine toxoids, which begin at 90476 to 90749. So we use two codes for immunizations. Again, one for the administration and one for the substance administered. They can be administered a variety of different ways: percutaneous, intradermal, subcutaneous, intramuscular, intranasal, oral. The administration codes are based on method of administration, so we do need to know, was it an oral or was it an IV? And some codes will be based on patient age and whether or not the physician did counseling. And we report each dose administered, single or combination, with the appropriate administration code. So if you look down at the two blue bullets, your 90460 and 90461 are for patients through age 18 for which counseling has been provided. You report the 90460 for each vaccine. The 90471 and 90474, the physician did not provide counseling, and it doesn't matter how old your patient is. So if you look at the two examples, we've got the example without counseling. So this person had 3 medications. So you've got the administration for the tetanus, and then you've got the tetanus. You've got the administration for rubella, and then the rubella. Then you've got the administration for varicella and the varicella. So you don't want to forget that administration code each time. Sometimes, again, the more you inject, you're like, I'm only, using the administration code once. No, you can use it individually. Now, there are cases where it may not be like with your diphtheria, tetanus, and rubella. It may be combined as one shot. You may have all 3 of those in one. So that would be a different scenario. If several vaccines were reported on 673, here's your administration for tetanus and diphtheria. So those 2 were combined. And then you've got your administration for rubella and then the rubella. So it just depends on whether they were individual medications given or if they are combined dose. You can see that Medicare reimburses for tetanus when given for an acute injury. When a tetanus booster is given in the absence of an injury, Medicare does not pay for it. So again, knowing what your payers are going to cover and not cover so that if it's not going to be covered, you've got the opportunity to have your patient sign that ABN, so at least you can bill your patient. So your vaccines and toxoids, 90476 to 90749, are vaccines for immunizations. They can be for a single disease as well as combination of diseases. And I mentioned that with like the diphtheria, tetanus, and pertussis in this case. Some may be specific to ages. So again, we need to be careful. Vaccines have adult, pediatric, adolescent, or dosages amount listed on the label of the vial. We have to review the description of the vaccine to make sure we are selecting the correct code. Again, when one code is available to describe multiple products given, we need to use that combination code. Again, if there is not a combination code and we're given 3 different medications, then we're going to list them all separately. You can see with Medicare, the pneumococcal vaccine. Normally, that's a 90732. But remember when we talked about our HCPCS book, Medicare's got those G codes. Well, Medicare has a G code for the pneumococcal vaccine. And when it is given, they want a specific Z23 code to go along with it. So if I was to bill that with a 90732, forgetting that it's Medicare and that they have a G code, they're going to deny it. So you've got to remember those G codes for Medicare. There are codes with schedules for vaccines, such as a 3 or a 4 dose. So if you look at 90633, 90633 is a 2-dose schedule for hepatitis A. So it's intended to be 2 dosage. Each time the vaccine is administered, we can report 90633 along with the date of the injection. The term schedule refers to number of doses provided and the timing of the administration. Your dosage and timing needs to be exact as specified in the code. So again, that's why when some people are given, like the hepatitis B might be a series of 3, it's real important to get those at the right times because otherwise, if they go too long, they may not be effective. If you look on 674, it tells you the CPT guidelines state modifier 51 should not be reported with vaccine toxoids when performed with administration. So therefore, most payers want you to report administration code multiple times or with how many units you are given. So if we gave 3 separate medications, we're going to have 3 different meds. We can list the administration code times 3, or we could list it 3 times. But again, no 51 modifier on your vaccines and toxoids. If the only service was for a vaccine, obviously we cannot bill an office visit with it, which makes sense. And then again, you can see some examples of the influenza vaccine being given and the difference of the dosage, 0.25 versus 0.5. And then again, the Medicare with the G code for the pneumococcal as well as the influenza. And again, Medicare's got their rules. So if we're given injections, we want to make sure that we're paying attention to their rules. So look on page 675 for an immunization. And we're going to do number 1. So we have a parent taking a 9-year-old child to the child's physician for a poliomyelitis vaccine intramuscular. Physician's assistant evaluates the child, administers the vaccine. So in this case, they are going in only for the poliomyelitis vaccine. So there's no office visit. So we're going to have the vaccine and the administration. Where would you start? I know you know where it is in your CPT book, but where would you go alphabetically if you were going to go look those up?
I would go look it up under that poliomyelitis.
Poliomyelitis? Okay, try that. While you try that, I'm going to look under vaccines just for grins and giggles.
It says C vaccines and toxoids.
The vaccines
Oh, yep.
and toxoids, all right. So,
Intramuscular.
Yeah, 90713.
and 90713. Poliovirus vaccine inactivated for subcutaneous or intramuscular use. Okay? So 90713 fits. And now, and this is the same. If you just flip back a couple of pages in your CPT book, again, right after where it's given the guidelines about the vaccines and toxoids, you again see in the wording, it says use this in addition to the administration code. So you could see where the administration codes start from there and go back to do your administration. Or you can just go look at your administration codes. We only have 6 of them.
Would it just be the 90460 because they're under 18? But it says with counseling. So is the other one? Hold on. 90460?
It's not 90460 because if you, that code, yes, our person was 9 years old, but in that description, it says with counseling by physician or other qualified professional. All it says here is the physician assistant evaluates the child. It does not say they provided counseling.
Can you use 90471 even though it's not, doesn't say younger?
Yeah,
Okay.
you can.
That's,
You're not-
that's
you're
what I
not-
thought it was, but
Your 90471 does not make a difference on age. That's the one
Okay.
you use when there was no counseling, period. So that's something you need to watch. Yes, some of the codes are age specific, and I would underline 9 years old because I know some of the codes are age specific. But then you've got to remember that counseling. If there is no counseling, you're not using either the 6.0 or the 6.1. Good. Now look down at number 6. A parent brings an 18-month-old who's established for a well baby exam, which is a separate service. So this one we're going to have an office visit, at which time the physician gives a vaccine intramuscular for diphtheria and tetanus after counseling the parent on the vaccine. So, okay, so let's do the vaccine. You're already here. This one does say counseling, and the child is 18 months old. So this time you're going to have what code for the administration?
90460.
90460. And now let's go to the vaccine codes and find the diphtheria and tetanus.
All right, so what does this say again?
And it was intramuscular.
Actually, hold on.
90700.
Yeah. No. Hold
90700 also has, it's not, that one is diphtheria, tetanus, and pertussis.
Okay.
So then it's
So it
90702.
90702, yep. And now if you look at your codes, the vaccine code, and then we actually have 2 spots for the administration. So you actually would use that add-on code for the counseling for the injection, which I think was what,
90461.
90461, yep. I forgot to do that, sorry. So now what do we do about the well baby exam? The well baby exam is considered like a yearly or a preventative exam. So you can either go to your evaluation and management codes in your CPT book and screen through them, or I would try either examination or preventative in the back and see if it leads us to what code it is. remember, this did say she's not a newborn because she's 18 months old, but it did say she's an established patient.
Would it be, would we look under well baby care?
Let's check. Well, baby. Let me look and
Because
see.
it gives you 99381, 99391, and 99461.
Okay,
So
well,
under-
go to those codes, and what did you find?
Under preventative medicine, there's established patient,
Okay.
99382 and 99397.
All right, so you go there and check those codes, and you go to the ones that led you to for well baby.
So,
Whoops.
The only problem is there's no 993s in here, so
Well, remember your your yearly exams and
Yeah.
that type of stuff is in your E&M code.
99382.
But 99382 is for a new patient.
Oh, yes, okay. It's 99392.
99392, yes. So yes, the well baby also led you to the same place. If you went to
Oh, yeah.
preventative and established, you got there too.
Yeah.
So, yep, you have your 99392 for their yearly exam, and then the administration for the meds and the med itself. But again, if this child was just going in for the injection, then we're not going to have that office visit code. All right, on 676, and then in your textbook on to the next section for psychiatry. And again, if you look at psychiatry in your CPT book, there's lots of notes and guidelines with regards to psychiatry. So, psychiatric treatment at the same time as an office visit. We can report one code for the therapy with an E&M code, and then we can build a psychotherapy code, 90833. So you see the psychotherapy codes start at 90785 to 90899. And again, lots of notes with regards to this. We have partial hospitalization, which is a hospital setting where the patients are in the hospital during the day and return to their home in the evenings or weekends. The facilities may be open during the day 5 days a week. Some facilities are 7 days a week. So the patients are not there overnight. So in this case, we may have some additional E&M codes for subsequent hospital visits as well. Psychiatrist, a physician specializing in psychiatry, practice of diagnosing and treating mental disorders. And then we have a psychologist. This is not a physician. They are a qualified specialist in psychiatry. So again, depending on what services are needed would be which one they would see. And some third-party payers may restrict the types of services that a psychologist can get reimbursed for because they are not a physician. They are a qualified person. Time is a major billing factor in psychiatry. Time needs to be documented. So this is a big one. Codes are divided on time. So your medical record needs to indicate start, stop time. 90791 And 90792, psychiatric eval and comprehensive service. And this would be gathering complete medical history, family history, psychiatric history, establishing a tentative diagnosis, evaluating their ability and willingness to work to solve the problem. It also includes a complete mental status exam, which can be from the patient, other physicians, and or family. Again, an E&M service may be substituted for the initial interview process, which would be possibly a consultation code if it's an opinion that another provider is asking for. And please remember, with the consultation codes, there are carriers that do not cover consultations. Medicare, MaineCare, any of your federal programs do not cover consultations. Psychotherapy is a therapeutic treatment of a psychological disorder or behavior. It's reported with 90832 to 90838 based on time, 30, 45, and 60. And then it's further divided based on whether it was provided in addition to another procedure. Again, time spent needs to be recorded. If it's not, the physician needs to be queried, asked, and the problem with that is if the time's not documented and they don't add the time, if you get audited, that's going to be considered a non-billable visit period because there's no time documented. Very similar to if you do not have them have a chief complaint. There's no chief complaint and somebody audits, non-billable visit. There's codes for crisis psychotherapy, 90839, 90840. So again, this is in crisis situation, drug overdose, attempted suicide, severe depression. Some patients receive psychotherapy only, and others will receive psychotherapy and maybe an office visit or a procedure, whatever it happens to be. Again, medical record must indicate time for the psychotherapy. Your record also needs to document symptoms, goals of therapy, monitoring the outcome. And again, if this is something your provider is doing, hopefully they know that. But it doesn't hurt to stress to them what needs to be documented. So look down at 26.2 and look at number 2. We have psychological testing, 2 hours, administered by a physician. Your patient's diagnosis is moderate, under-socialized, aggressive outburst conduct disorder. Wow. All right, so psychological testing, 2 hours, administered by a physician.
You want us to go into the back?
If you're going in the back, where are you going to?
I'm going to go to psychological testing.
Okay.
I was going to go to psychological.
Okay, let's do it. And not spelled tonight. This is why I didn't go to work today. Whenever I have a headache and a migraine, I cannot even focus.
Ugh.
I don't see psychological unless I
It's
can't
not in
spell.
there.
Okay,
not.
phew.
I don't know.
What
Testing?
about psychiatric treatment? Is there anything under that for testing? No.
I didn't even see that.
It's above. It's on there.
Oh,
Psychiatric treatment. I forgot what we were looking
Yeah, I don't see any testing though.
No, I don't either.
Oh.
don't see it under test either.
So, okay. It's not under test and it's not under psychological. So go back to the psychiatric treatment and look above it. Psychiatric diagnosis.
Testing, I see it. Psychological testing.
Yep. Let's try that. 96101 to 96103. That really? What? No, I don't know. That doesn't seem right.
No.
Psychological testing.
Would it be? Would it be under?
Maybe it. Did we check? Let's check that. Well, let's check that 960 whatever code it was.
I'm looking at it, but it says a bunch of stuff.
Okay, 96101, psychological testing. So it's telling you what it includes. So
Oh, okay.
all those things are included. So we would not break it apart and bill it separate. Then it says per hour of the psychologist or physician's time, and that's face-to-face administering the test and time interpreting the results. And then if you look down below, 96102 is also physiological testing, but it's with a qualified healthcare professional. And 96103 is administered by a computer. So which one would it be?
Well, I'm confused that it wouldn't be any of them because it says by the hour, and this is only 30 minutes.
No, we're doing number 2.
Oh, 2 hours. Jeez Louise. Okay. So then,
Per hour.
it's going to be 96102. Qualified healthcare professional, because it's not a psychologist, it's a...
But read 101. It says
Say
psychologist or a physician.
Okay,
So it is 101,
okay.
and then you're going to have it times 2 because it was 2 hours.
Okay.
And if it helps when you're taking the exam to bring a ruler so that you know which one you're working on, you can put your ruler
Yeah.
under that so you're not looking up at the one above it or whatever. I know some people that helps, get to where they need to. Okay, good. So that one was a little bit different. Now we're going into biofeedback. So biofeedback is the process of giving a person self-information. So blood pressure, heart rate, pain. Patients are trained to use biofeedback by a professional and then use the therapy on their own. So when biofeedback is part of an individual psychophysiologic therapy, one code is reported for both biofeedback training and the psychophysiologic therapy, 90875 to 90876. And you can see there, those 2 codes, the only difference, one's 30 minutes, one's 45. So your biofeedback codes, 90901 and 90911, they tell you can look either under training or biofeedback. So with that being the case, look at number 2. We have a 52-year-old referred to the physician by his primary care for biofeedback to help regulate blood pressure. He was diagnosed with hypertensive heart disease, no evidence of heart failure. Physician conducts 60-minute session where the patient is trained in the use of biofeedback. So in the back, I just told you, you can either go to training or biofeedback. Probably going to lead us both to the same place. Remember,
What
go
is
ahead.
So anorectal means.
Anorectal means up through the rectum.
Yeah. Okay, that's what I thought. So then it's either going to be 90875 or 90876.
Okay, but look above the exercise, and it said biofeedback codes 90901 or 90911.
11. Is it 90911?
Let's see. If you went to the other one, which I went there first, that includes the psychophysiological training, and in this one, all he's training for is for the blood pressure. So it would strictly just be biofeedback. So biofeedback, the 90911 is for perianal muscles, anal rectal, or urethral sphincter. And
Yeah,
he
you
didn't
might
do
not-
any of those because he's just training, he's training the biofeedback on the blood pressure.
Yeah, you wouldn't want to look biofeedback because I went to biofeedback and it either gave me the anorectal and I read nothing in here said anything about rectum, so that's why I said the other one said psychological. Those are the two options under biofeedback training.
Yeah, so if you went to training and then biofeedback, it leads you to the 01 and the 11, and in this case it would be the 01 because it's not anorectal.
They don't even have that as an option under biofeedback training.
Oh, good. Yep. Well, nope, it's only 90901.
Yeah.
And again, if your physician is doing these types of service, you're going to be pretty familiar with that. There's only, two specific codes for biofeedback. Okay, after the biofeedback, you see we have dialysis. Again, lots of notes in here on dialysis. It's cleansing of the blood of waste products when your body cannot do it on its own. Dialysis can be temporary for somebody in acute renal failure, or it can be permanent if they have end-stage renal disease. So we have codes 90935 to 90999, and it is divided based on the type of dialysis. You can see up on 679 in your textbook the types of dialysis broken up by age, how many visits per month. If the physician does the same evaluation and management to somebody receiving home dialysis, the monthly service is based on the age of the patient. And if the physician provides same services for less than a month, also based on age. So that's a good little tool to help with the codes. Hemodialysis, routing of blood and waste products outside the body. It's filtered, cleaned out, and then returned to the body. 90935 and 90937. Each day the service is performed. So 2 codes, just depending on each day the service was performed. Then you have peritoneal dialysis, 90945 and 90947. This uses the stomach or the peritoneal cavity as the filter instead of the outside of the body. Again, peritoneal dialysis reported on the basis of each day service is performed. Now, sometimes patients are taught how to do dialysis themselves so that they aren't required to go to a facility and have it done. But again, that's going to depend on their situation, their understanding, that type of thing. But you can see an example on 679 of the peritoneal dialysis, and then the catheter and the cavity and all that fun stuff. On page 680, end-stage renal disease. 90951 to 90966, and again, any treatment of patients with end-stage renal disease. These are listed according to patient age and number of visits. These are reported on a monthly or as a monthly fee. So they're not reported every time they come in. You accumulate and then bill on a monthly basis. If they don't require a full month, then yes, daily fees can be reported with 90967 to 90970. Some third-party payers will allow you to bill an office visit in addition to the dialysis, but most of them consider the dialysis code to include the office visit, so they typically will not pay for it separately unless you can document that the office visit is for something completely separately identifiable, and then you can use the modifier 25. Dialysis is usually done outpatient, hospital, or outpatient facility. The physician services are based on type of dialysis, complexity, and number of visits. The reporting of just one code covers all physicians' visits during that month. The monthly code can also include nutrition assessment and telephone calls. So again, you've got to have, if you're billing for these or anything that you're billing on a monthly basis, you've got to have a separate way to track those patients so you don't forget to bill them like at the end of the month before they start their next month's treatment. Because you want to get that money in for your provider. He's been waiting a whole month for something he's done at the beginning of the month. Dialysis patients sometimes can be admitted to the hospital. And while they're in there, they're going to have their dialysis treatment. When physicians assess the inpatient while undergoing dialysis, we can report 90935 for a single visit or 90937 for multiple visits. Again, that's if they are hospitalized. If the patient is receiving peritoneal dialysis, inpatient, and they are assessed by the physician, 90945 single visit, 90947 multiple visit. Modifier 26, not used on these codes because the description says only physician service. And again, when the patient does not receive a full month, let's say because of a kidney transplant, they relocate, they pass on, report the number of days the patient had dialysis. So that code times the number of days so you can get reimbursed. So look down at the exercise and look at number 1. We have a 10-year-old. She's got end-stage renal disease. She had 3 encounters during a full month. So hemodialysis, 3 encounters. And she's 10.
Hemodialysis.
Did you go to hemodialysis?
Yeah.
Yep.
Okay.
I'm just gonna look up that 90135.
Not seeing anything under
90937.
9037. Okay, that's just regular hemodialysis. This girl has
Yeah.
end-stage renal. So, so under hemodialysis, yes, that's where it leads you. Try going to end-stage renal in your alphabetical index.
Yeah, because that other one doesn't really bring you.
Yeah, no. What stage are you
90967.
Now, I heard you say 90967. Why did you say that? She did have a full month of treatment.
Because it was, whenever it gives me a range of numbers, I always remember one of them so that I can look
Gotcha.
around there.
Gotcha.
But, so it's actually, where are you, 10? $90968.
The only problem with that is you are under less than a full month of service. She had a full month of dialysis, it says. It said that during a full month of hemodialysis.
Okay, I was thinking three
Right.
encounters weren't a lot. So then it's the one that is 90964.
Okay, read that carefully. Services for home dialysis.
What am I even looking for? 10-year patients encounters during the full month.
So she had a full month of
Okay, so I see, but there's a star next to it,
Yeah,
Okay, that's all right.
but,
that says telemedicine.
yeah.
That's okay. It can include telemedicine. So that means that code can include that doctor looking at stuff via the telephone. If the recordings were transmitted, doesn't mean you can't use that code.
Okay. So is it 90958?
90958 is for a patient 12 to 19.
Yeah, 90955.
90955, correct.
Yeah, okay.
2 to 11. But do you see how sometimes it's one word
Yeah.
or like the
So it don't matter that it's telemedicine,
No,
that's fine? Okay.
it can be, telemedicine can be part of dialysis.
Okay.
And I think if you read the, the notes there, it says something about that in those notes for all that dialysis notes, all those lovely little notes. All right, now we're moving on to gastro.
Holy moly.
Yeah.
91010, I know, 91299. These are on the esophagus, stomach, and intestines. Again, carefully reading the code description so we know what is bundled and not bundled. So, there's not many codes. Look on 682 and look at we're going to do number 1 and then we'll do number 2. So number 1 is a 2-hour gastroesophageal reflux test with nasal catheter intraluminal impedance. So the patient has GERD. Okay, so gastroesophageal reflux test.
Do you want us to go to the back just because?
No, no, because remember, I've taught you. You know that that's how you're supposed to do it. And on the exam, you don't have to do it that way. So if you feel comfortable, then that's fine with me. 2-hour gastroesophageal reflux test. If you went to the back under gastroesophageal reflux test, I will tell you, to narrow it down for you, it went from 91034 to 91038.
Is it 91038?
Esophageal function test with nasal catheter implant, blah, 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 prolonged greater than 1 hour. Yes, it is. 91038.
Oh,
You
geez,
got it.
fine.
You got it. 91038. Now what about the second one? Colon motility study, 7 hours. Continuous recording.
For 7 hours? I think it's 91117, but then I think you must have to have an add-on because that's a minimum of 6 hours. So where's the?
Right, it's a minimum of 6 hours. You did it for 7 hours.
Okay,
says-
so then,
Yeah, it just has to be 6 hours. As long as it's 6, it doesn't matter how many hours it is. You're going to get paid as long as you do 6. And if you went to the back under the alphabetical index and went to motility of colon, it gave you that one code.
okay.
So again, some of them are going to be pretty direct, but if you're comfortable enough knowing you're already in that section, that's fine. Okay, ophthalmology. 92002 to 92499. So the ophthalmological services are specialized field. Ophthalmologists treat your patients for diseases and injuries of the eyes. Again, extensive subsection notes require reading. General ophthalmologic services, routine eye exams are located under general ophthalmological services. These are based on whether the patient is new or established and the complexity of the service. So your two complexity levels are intermediate and comprehensive. And again, you remember from when we talked about E&M way back, your new patient is somebody you have not seen within the past 3 years, and an established patient is somebody you have seen within that time frame. The ophthalmological services contain bilateral codes, which means obviously they need to be done on both eyes. The codes do not require a modifier as long as both eyes were examined. If it says bilateral and you only did one eye, you need to use your modifier 52 for reduced services. That lets them know only one eye was done. There are ophthalmological services not normally performed in a general eye exam. Some are required under general anesthesia, so manipulating the globe for range of motion, for example, 92018. Other codes in this subsection, provision of materials for the patient. So again, the contact lenses, ocular prosthesis, eyeglasses, refraction that is done by a physician for the lens prescription may be reported separately. It depends on your insurance carriers. Making a decision to assign an ophthalmology code or an E&M code is determined by the service provided. So if it's, again, specifically ophthalmological related and your documentation has certain things in it, it may qualify for a regular old office visit exam. If it has these types of testing, external exam, visual acuity, visual fields, tonometry, evaluation of complete visual systems, then that's a eye exam code 92002, not an office visit code. An office visit code for an ophthalmologist might be, for example, that you got something in your eye and you're going in just to have your eye assessed for that, not for a complete eye exam, not checking your visual fields, but because something's going on. An intermediate service, 92002 to 92012, describes evaluation of a new or existing condition complicated with a new diagnosis or management problem not related to their primary diagnosis. And then your comprehensive, 92004 to 92014, general evaluation, complete visual system. The initiation of diagnostic and treatment program by prescription of medication or arranging for special testing, consultations, possibly radiation, that would all be included. Excuse me. Look on page 684 and look at the 26.6 and look at, which one do I want to have you do? Let's do number 2 and 4. So fitting of a contact lens. The patient's diagnosis is ocular surface disease. Fitting contact lens. And again, I don't care if you go out back or look there.
(92071).
Let's see. For ocular surface disease, correct. 92071. And see, again, underneath that, it tells you to report supply of lenses separate. So if you were giving them or providing the lenses, you could also bill your HCPCS or supply code. Okay, what about number 4? New patient comprehensive ophthalmologic exam. New patient comprehensive ophthalmological exam.
The new patient.
Should be what?
92002.
Okay. What's the difference between 2 and 4?
Comprehensive new patient.
Or intermediate, right?
Right.
So this patient has type 2 diabetes and proliferative diabetic retinopathy. And if you look back, it said that comprehensive is a general evaluation of the complete visual system. And this was it tells us it's a comprehensive. So it would actually be the 92004.
Okay.
See how it says new patient comprehensive?
Oh, yep.
Yep. And you'll see when I do the practice exam with you guys, if it helps you to, you can use a highlighter on the exam. I just used the same pencil I was using because to flip a cover off and on and stuff just was, but underlining those keywords sometimes will help.
Mm-hmm.
Now, the 92502 to 92700, ear, nose, and throat. Hearing testing, for example, this can be done by a physician or an audiologist. Some, again, codes for ear, nose, and throat will be surgical, but we do have special ones. So you can see gonioscopy, computerized corneal topography, sensoromotor exam. So just look on 685 and look at number 4, nasal function study, inadequate respiratory flow. Nasal function study.
Nine two five one two.
Oh, you guys are too fast. Yep, 92512. Nasal function studies, and that's also referred to as a rhinomanometry. Good. All right, look at that. Congratulations. You will soon be finished with the entire CPT.
I can't wait.
All right, we're almost there. Cardiovascular. We talked about a lot of these in chapter 17, but here we are going to have some invasive, non-invasive cardiology codes. 92920, 92998. And again, if you look at your cardiovascular, we've got a lot of codes in your CPT book that are documented as being out of sequence. And you do have lots of, again, your notes with regarding cardiology. But this would be like for your CPR, our cardioversion, converting them from abnormal rhythm to normal rhythm. Percutaneous transluminal coronary angioplasty, or PTCA, 92920, 92921. Cardiography, 93,000, 93278. Your implantable and wearable cardiac devices, 93279 to 93299. And your echocardiography, 93303 to 93355. Again, you don't have to remember what cardiology codes are in the medicine section, because when you're looking them up alphabetically, if it leads you to the surgery section and you know you're not doing that specific surgical procedure, then it probably has a code that begins with a 9 that's going to lead you to the medicine section. Your cardiac cath codes are in here, 93451 to 93572. This is a diagnostic medical procedure. When they do right heart catheters, they are measuring and recording your right atrial, right ventricle, pulmonary artery, and pulmonary capillary wedge pressures. And this can help diagnose congestive heart failure and right-sided valve disease. For the left side of the heart, they would be going through the femoral artery, but they're looking, going through the ascending aorta, aortic valve, into the left ventricle. This helps diagnose coronary artery disease, left ventricular dysfunction, and valve disease. So again, just depending on what side of the heart they are looking for things on. Also in this section, 93880 to 93998, procedures conducted to study veins and arteries other than the heart and great vessels. They use the same devices that are used in the heart and great vessels, but they are different arteries and or veins. So look down on 686 and look at number 1. The patient is being referred for a single level bilateral venous occlusion plethysmography of their legs. So it's a single level bilateral venous plethysmography. So I'm probably going to start with that lovely word, plethysmography, if I can spell it. The legs. Because as you can see, that's a big section, so it's probably easier to look these ones up alphabetically.
Limited bilateral non-invasive. $93922 with 52.
And why do you say that?
Because I read it says limited non-invasive study upper or lower extremity, but then if you look down, when only one arm or leg is available for study, report 93922 with 52. If you don't do both legs. Oh, no, it says of legs.
Right.
So
of
then
legs.
93922.
But this is a limited, and let's see, single level, limited, hang on, complete 3 more levels. So that's 1 or 2 levels.
Because the other ones have a lot of I think.
Invasive physiological study upper or lower extremity arteries. So I would have to agree with you on this one. And the only reason I was hemming and hawing is because that's not the answer they give you in the book. The answer they give you in the book is the 93924. But when I read the 93924, it says at rest and following treadmill stress testing. And I, in no way, or you, would be able to tell that that person had a treadmill.
Yeah, it doesn't. That's why I didn't. Everything else had either. It had like.
Well, it says, I don't know what that word is, claudication,
Yep.
and it has it in that 93924. But it really doesn't.
What are the time of onset of claudication?
But I don't.
Yeah, that may be the key right there, is that word claudication. But that's something that
Because
I would,
I was
without
going to
that,
say that, but it doesn't say anything about stress tests or treadmills or.
right, and that's why I would lean more towards the 93922. And I'm going to put a question mark there so that I can look into this a little further to find out. Maybe it's something that particular, if we read all the notes there, maybe that particular test is automatic for a treadmill. I don't know. But I would say if you came up with either one of those, that would be okay. And I will check into finding out if the word clonification is the reason they picked the other one. Because, again, without that verification of them having a treadmill, I would not pick the 2-4 because I don't know that they had a treadmill.
Yeah, it's just weird too. It just says the patient has complained.
Right.
It doesn't say
And
that
I
they-
thought that that intermittent leg claudication would be the ICD-10 code, right?
Right. Yeah, because
So-
the patient has complained.
Right.
Is there any documentation that they really had claudification? So, okay, see, that's a good one. All right, let's go to pulmonary. 94002 to 94799. These are your nebulizer treatments, spirometry, pulmonary function test. Nebulizers are a spray which is inhaled, typically for people with asthma. Your pulmonary function test monitor the function of your pulmonary system and your lung capacity. Several indicators need to be present from a variety of tests. So in order for them to do certain things, the tests have to show certain things before they can move forward. Each type of test would be reported separately unless it is specifically stated otherwise in the code description. You need to add your 26 when you are reporting the physician interpretation only. And again, that's not owning the equipment. These ones are pretty straightforward, so we'll skip over those codes. Let's go to allergy and clinical immunology. And again, you look in your CPT book, we've got some notes with regards to these. Again, telling us to read the notes carefully. 95004 to 95199. It's divided into 3 parts. We have allergy testing, which can be done percutaneous, intracutaneous, or inhalation, and then the type of test that we're doing. The number of tests always has to be specified because the payment is per test. So again, we don't want to short our providers. Allergy testing includes or consists of performance, evaluation, and interpretation of allergens. Also, it should be based on a complete history and physical. Second subheading is ingestion challenge testing, 95076 or 95079. One is the initial 120 minutes of testing time, and then the add-on is each additional 60 minutes. And then your third subsection is your allergen immunotherapy. Your codes specify 3 types of service: injection only, prescription and injection, or supplying the antigen only. So again, these have specific notes that you need to read to know whether the code is just the injection, the medication and injection, or just the antigen. So, for example, if you look at 95115, it says professional services for allergen immunotherapy, not including provision of extract. So this one is just the injection, does not include the antigen. With allergen immunotherapy, the dosages can be repeated, so we can have repeated administrations of allergens for the purpose of providing protection against the allergic symptoms and reactions. Immunotherapy can extend over a period of months, and when they do that, they are typically increasing the dosages, which builds up your tolerance of the antigen. Hopefully, when they're doing that, your symptoms are declining, and then your need for medication is less because you're going to build up all those antigens against that. So look down at number 2, percutaneous test using allergen extracts. Immediate type reaction, 10 test. Percutaneous test using allergen extracts. Immediate reaction.
Nine five zero zero four.
95004, percutaneous with allergenic extracts, immediate type reaction, including test and interpretation. And how many tests?
10.
Times 10, correct.
Yeah.
Now look down at number 4. Physician prepares a 10-dose multi-vial allergenic extract for a patient. At the same encounter, 1 dose from the vial is administered by 1 injection to the patient. So he prepares a 10-dose allergenic extract, and then the patient is given 1 dose at the visit. Dose multi-vial allergenic extract.
Can I just ask you something real
95144.
95 what?
144.
95144, professional service, supervision, and preparation of antigens for allergen immunotherapy. No, only because if you read that, it says single dose vial.
Yeah.
And this
so,
says multi-vial.
So 95165.
95165, yes. And somebody have a question?
Yeah, I was just going to ask you something because I was looking at these and I'm reading them. Why does it say professional services for the supervision of preparation? To me, that sounds like somebody's watching somebody else.
Right, but I know it does. But the physician himself is actually preparing the vials.
Okay.
So because he's preparing them, they're able to bill for that.
Okay.
Yeah.
So
I know you're right. Supervision
supervision means doing.
Yeah. Yeah.
So
you
then
got that
95165 times 10, right?
times 10, and then he's at the same encounter, they're using one of those dosage from the vial and giving it to her. So now we need just the code for the injection. We're not going to build
95115.
95115, correct. Professional services, allergen immunotherapy, not including allergenic extracts, right? Because he took it was from the multi-dose, so he's using one of the 10. So she's got 9 left. Yep. And again, if you're doing like this type of thing all the time, it's going to be, much more familiar for you. Endocrinology, we have codes for glucose monitoring, 95250, 95251. They can monitor a patient's glucose continually with a probe under the skin, and they wear a monitor, 72-hour period. They remove the probe, the data is downloaded. Patient records their insulin administration, meals, exercise, any events that they might have. This service includes initial hookup, calibrating the monitor, training your patient, removing the sensor, printing the recording, and interpretation. 95251. So that includes all of those things. Then you've got neurology and neuromuscular. 95782, 96020. Sleep testing, muscle testing, range of motion, cerebral seizure monitoring, and some neurologic function tests. Again, typically it's done by a neurologist, somebody specializing in neurology. When they do sleep studies on newborns, it's performed by a pediatric pulmonologist, not a neurologist. One of the specialized tests, again, is a sleep study, 95800 to 95811. They monitor the patient's sleep for about 6 or more hours. It includes the tracing, which is the technical component, and the physician's review and interpretation and report, which is the professional component. So because it includes both, if your provider only did one portion, we need to use that modifier 26. If you look on 690, this is what a sleep study looks like for a patient with sleep apnea. They diagnose sleep disorders. Sometimes they will do an EEG, an electroencephalogram, which records brain waves. Polysomnography is the measurement of brain waves during sleep, during different stages. So they can tell if you're excited, relaxed, drowsy, you're just asleep, or if you're in a deep sleep. It's recorded during each stage. Rate and amplitude of the brain waves are measured and compared with normal. So they are able to tell by looking at the brain waves if there's something going on and if you're getting good solid sleep or are not getting sleep, and if you've got issues with sleep. Nerve conduction test, 95905 to 95913, usually done in conjunction with motor nerve condition studies of the same nerve. May include what we call F-wave studies. 95907 to 95913 are reported for each nerve tested, regardless of the number of stimulation sites. So it's per nerve. Doesn't matter how many times they are stimulated. And if you wanted to, Appendix J has the specific nerves that are listed for the codes that can be tested, 95905 to 95913. These are both sensory and motor nerve conduction study tests with or without that F wave. The 95905 is using pre-configured electrodes. There are parameters that are measured during a sleep test. Snoring, it can measure blood pressure. Depending on how many parameters they are looking to measure, it can be done during these types of tests. To report sleep tests accurately, you need to know how many parameters they are measuring and those specific stages. Additionally, a lot of codes may have a time component. So again, having when the patient fell asleep and when it was, finalized, that needs to be recorded. Your EMG studies use needles and electric current to stimulate nerves and record the results. And this can be done for a variety of reasons as well. So if you look down at 2611, take a look at number 8. Needle electromyography, 3 extremities, and related paraspinal area. So needle electromyography, 3 extremities, and paraspinal area. See what you come up with for that. Did you go to the back or did you just go to that section?
I went to the back.
Me
Okay.
too.
So you went to electromyography and then needle extremities.
Yep, 9-5.
Extremities, okay.
Nine five eight six three.
95863. Right, 3 extremities with or without related paraspinal. 95863, correct. And again, if you look in your CPT book, there's a few notes that are telling you can, some codes are once per extremity. There are a couple codes can be reported together up to 4 units. So again, making sure you're aware of those special guidelines. The central nervous system, 96101 to 96127. Psychological testing, speech, language, developmental progress, reasoning. These are per hour basis. So again, it needs to be included in the patient chart. We're not gonna do those examples. You can see they're pretty straightforward there. They are, again, based on time. Health and behavior assessment, 96150, 96155. These are not preventative services. These codes are assessment and or intervention for behavioral, emotional, social, psychological, or knowledge factors affecting their health. So assessments can be clinical interview, observing their behavior, questionnaires. Interventions can be individual with a patient, group, and or family, and again, based on time, 15 minutes. These are not performed by a physician, so they're a qualified specialist. Hydration codes, 96360 and 96361 are hydration. And again, if you look, there's lots of notes here with regards to hydration codes. These codes involve oversight of the treatment plan and staff supervision. When they do provide a significantly separately identifiable office visit, then you could bill the office visit with the applicable modifier 25, have a different diagnosis code, but you can have a billable office visit with hydration for a different problem. Now, bundled into these hydration codes are your local anesthesia, placing the IV line, assessing an indwelling catheter or port, flushing after the infusion, and all standard supplies. So these codes report intravenous hydration infusion. It includes the prepackaged fluid and electrolytes. If you are using something other than prepackaged, you can report it separately. Now, saline is not reported separately unless it is the only thing given for hydration. So usually the hydration is in another form. It's not saline. But if it's strictly saline that is given, that can be billed separate. Again, you will note these codes include physician supervision and oversight of the staff, 31 minutes to an hour of IV infusion for 96360, and then your add-on code is each additional hour. Very important, if it is under 31 minutes, it is not billed as hydration. You would have a regular old office visit code or a hospital code if they're an inpatient. Less than 31 minutes, not reportable. We then have therapeutic, prophylactic, and diagnostic injections and infusions. And again, you've got some notes with regards to those. 96365 to 96379. Intravenous infusions, are 96365 to 96368. They are based on time and type of infusion. Your initial infusion is the 96365, and then each, which is an hour, up to an hour, and then each additional hour over 30 minutes is 96366. Now, sometimes you're going to have one infusion followed by another with a different medication. That is referred to as a sequential infusion. This case, your initial infusion is listed first, and then you use the add-on code for the sequential infusion listed separately. There are times when more than one infusion is provided at the same time. This is called a concurrent infusion. One site with two lines infusing at the same time. Report initial infusion first and then concurrent infusion. You'll see we have codes 96369 to 96371, which are for subcutaneous infusions. These include initial setup and the first hour for the 69 code, each additional hour with the 70, and then if there is an additional setup for a new infusion, that's the 71. To report therapeutic, prophylactic, or diagnostic injections, the 96372 to 96376, doctor has to be there. So if you look at those codes, hopefully, let me see, 96372. Actually, that does not say that the doctor needs to be there. That might be a note that you put next to it, because it does clearly state that the physician must be present.
So which one is it? 7-2?
96372 to 76. I'm surprised it doesn't say physician's presence, but the 76 is an add-on code. It can be reported only when the service is provided at a facility. These codes are divided based on the method of administration. Subcutaneous, intramuscular injections are 96372, in addition to the code for the substance. If you look down towards the bottom, gives you some examples: subcutaneous, intramuscular, IV, and intra-arterial. Administration codes for vaccines and toxoids, we already went over that. The code 96372 is not used to report chemotherapy. Your chemotherapy codes, if you look, are in the next section, 96401 to 96549. So even though it says therapeutic, prophylactic, or diagnostic injection of a drug, it is not a chemo drug. We talked about the allergen immunotherapy codes. That's the section we just did, the 95115 to 17. But again, the intra-arterial is under the 96373, which you can see in the 74 is an IV push, and then each additional IV push is the 75 and 76. Here's the chemo, 96401 to 96549. The first set of codes, the 01 to the 17, is subcutaneous, intramuscular, intralesion, or IV chemotherapy. Your intra-arterial chemo codes, 96420 to 96425, chemo administered via your arteries. And then there are other administration routes, 96440 to 96549, plural, for example, via an indwelling port, central nervous system. So again, depending on what the method is that they're administering that. There are two other sets of codes for chemo: hydration, 96360 and 61, and then the therapeutic, prophylactic, and diagnostic injections, the 6365, 6379. Again, we already talked about any injections that you are administering where you are supplying the medication. It's either the appropriate HCPCS code or that generic supply code with a description. Included with your chemo infusion code 96401 to 96549 are local anesthesia, starting the IV, accessing the indwelling IV or subcutaneous port or catheter, flushing it out once it's done, standard tubing, syringes and supplies, and prep of the chemo agent. So when you get hooked up to an IV in the ER, that whole little long tubing with the needle and everything, that's all part of the kit. Now let's say for some reason something happens to the tube. Then if you need to supply more tubing, then you can bill that additional tubing. But standard tubing, syringes, and supplies, which are considered the norm, you would not bill for separate. Initial IV infusion is 96365. Each additional hour up to 8 hours is 96366. And again here, if you have the sequential, one after the other, it's 6-7, or the concurrent would be 6-8. And we just talked about the sequential and concurrent. Any administration that is 15 minutes or less is not an infusion. It is considered a push. So the administration of a initial or single IV push is 96374. And an additional push is 75. One push per drug. So it depends on how long it's going to take the medication to get in your system. If it's over 15 minutes, it's an infusion. If it's under 15 minutes, meaning they're trying to get it to you quick and maybe it's just a very small amount, it's a push, not an infusion. If two drugs are mixed in the same bag and administered for 15 minutes or less, again, the appropriate push code, and then the drugs or substance would be reported with the appropriate J code based on amount and type. Sometimes your patient's going to get hydration and medications before or after chemo. Only one administration per encounter. Other services can be reported with secondary or subsequent. And it gives an example on 695. The patient comes in for chemo. They have 40 minutes of hydration prior to chemo, so 96360. If the patient receives hydration before and after chemo, you calculate the entire time of the infusion. So 1 hour before and 40 minutes after. Total hydration time is 100 minutes. So you'd have 96360 for the first 31 to 1 hour, and then each additional hour would be 96361. So in this case, they can't report the additional hour because it wasn't an additional hour. It was only an additional 40 minutes. Modifier 59 should be reported to indicate hydration was provided prior or following chemo. That way you get paid for it. And again, make sure we are billing for the medications. All infusions must have a documented start and stop time. Sometimes during chemo, anti-nausea or anti-vomiting medications may be given. Medications are reported in addition to chemo because chemo was the primary service. So you can report those medications separate. Again, each is reported separately unless the medications are mixed together and given under one infusion. Then they are reported as one. And again, it says, after chemo, patient received Aloxi, Benadryl, and Decatron. 3 separate infusions of less than 15 minutes each. So they're not infusions, they are pushes. And so you've got your injection times 3, and then you've got each separate medication. Again, if all medications are mixed together, then you only have one infusion code because you're not giving them 3 different injections. You're giving them one. Again, at the bottom, if a significantly separately identifiable office visit was done, you can use a office visit with a 25 modifier. Obviously, it would have a separate diagnosis or a different diagnosis code. Look up on the top of 696. Again, it tells you that your chemo admin codes include the anesthesia, the ports, the flushing, the syringes, the tubing, and everything. Again, not reported separately. So look down at number 4. We have chemotherapy administered IV using infusion technique, 50 minutes. Chemotherapy administered IV infusion technique, 50 minutes. Are you going to chemotherapy? Or just looking in the section?
I was just looking at the section.
Okay.
Okay, nurse.
Yes.
Hmm. 96413.
Right, good. 96413 says up to an hour. Doesn't matter that it's 50 minutes. Good.
Okay.
Yep. 96413. Good job. Okay, the next section, you can see there's only 3 codes, photodynamic. 96567, 96571 are add-on codes. Well, 96567 is not the add-on. 70 and 71 are the add-on codes. Typo. Photodynamic, an agent is injected into the patient, remains in cancerous cells longer than in normal cells. And this is a treatment that is used. The agent absorbs the light produces oxygen, destroying your cancer cells. So it is based on time. You will see the first 30 minutes, each additional 15 minutes. If it is external application, so just the light, that's the 6-7. And you'll see that the 70 is an add-on because it tells you to list separately in addition to the endoscopy or bronchoscopy code, which is typically what they use these photodynamic codes for. Your next section is special dermatological, 96900 to 96999. Typically, a dermatologist would provide these services. These are for special procedures, typically reported in addition to the office visit. Maybe, for example, ultraviolet light, actinotherapy, which could be reported separately. You can see microscopic exams of hairs plucked or clipped by the examiner, whole blood integumentary photography, high-risk patients for dysplastic nevus syndrome, laser treatment for psoriasis. So again, unless they are only scheduled for these treatments and nothing else is being done, you would have just this code. If they're coming in and the doctor decides once they're in there to treat them, you've got your office visit and your treatable code. So look down at number 2, photochemotherapy, 34-year-old patient, and they have severe bullous dermatosis. It's 8 hours of treatment. The physician provides a comprehensive history and exam with decision making. So we've got our consultation first. They're telling us it's a 34-year-old consultative patient. So let's go to our consult codes and find a code for that office visit first. Which would be in your E&M section. Consult code again 99241. We're looking comprehensive history and exam and moderately complex decision making.
Nine nine 203.
That's an office visit. This says it's a consultative patient, which means it's a consult.
Okay, so establish no.
Alright, what is it?
So he did a history, physical exam, and moderate complex. Is a physical exam considered to be like a detailed? Is it like a full body?
Nope, because if you look, it says the physician provided a comprehensive history and exam. So you're looking for a comprehensive history and comprehensive exam.
99244.
99244, right, because you need all three key components. Now, because we are doing a procedure, what are you going to put on your office visit so that you get paid for the office visit and
25.
25, correct. Now let's find our photo.
In the coding, does that go first?
Your office visit always goes first, yes. And then let's find your photochemotherapy.
So what did that say? 34-year-old. Do you want us to go in the back? So photo.
Did you go to photochemotherapy?
Yeah.
So it led you 96910 to 96913.
I'm trying to find something that says severe bullous dermatitis. dermatosis, but
Look at 96913.
96913.
Right. 96913
oh, there it
says,
is.
yep. And it says at least 4 to 8 hours. 96913. Yep.
Oh, wait a minute. What photo? What is that? Sponsive? Is that the same thing as bolus?
Yeah. Yeah, photoresponsive means it reacts to light.
Okay, and okay.
Yep. And remember, not always is it going to be worded exactly
Yeah.
like we have it, but the key is to find, obviously, the one that's the closest and not something that means completely different. All right, now we've got our physical therapy and rehab, 97010 to 97799 by a physician or therapist. They are different modalities of treatment, traction, whirlpool, electrical stimulation, as well as types of training, functional activities, gait training, massage. They are on the basis of time or treatment areas. Codes are divided by supervision or constant attendance. So a lot of these codes can be unit coding, meaning you're going to have ×2 or ×3, whatever it happens to be. So you see the example, prosthetic training of 60 minutes would be 97761 ×4, because that one code is 15 minutes, so we want a code for 4. On 698, note the difference between an orthotic and a prosthetic. An orthotic is a support, splint, or brace. A prosthetic is a replacement. So the prosthetic means you no longer have that breast. You've got a fake one. Whereas a orthotic is supporting that limb or finger, whatever it happens to be. All services provided by physical and occupational therapists require a written referral from a physician, so they need an order. Services are also rendered according to a written treatment plan. So they do need to document history, exam, diagnosis, related physician orders, therapy goals, any contraindications, how the patient is progressing, how long they're expected to need treatment, and documentation needs to be maintained in the medical record. Physical therapy test and measurement codes are listed by type of testing and time required. Again, for all codes time-based, the time needs to be documented. We have a few codes for active wound care. This is non-physician personnel. 97597 to 97610. The 97 and 98 are selective debridement services by high pressure water jets, scissors, scalpels, or forceps based on first 20 square centimeters or less, and then each additional 20 square centimeters or part thereof. So that's important because that means it doesn't matter how much over the 20 square centimeters, as long as it's part of the next 20, you can bill that. These codes are based on non-selective or negative pressure. So non-selective is where they remove, healthy tissue is removed along with the necrotic tissue. This is usually done over several visits, not just one. We have negative pressure wound therapy, 97605, 97606. This can be vacuuming and draining the tissue from the area, putting topical medications or ointment, assessing the wound, continued care of the wound. Choice of code is dependent on square centimeters treated. I'm not going to do the physical medicine ones. Those are pretty straightforward. Medical nutrition therapy. You'll see we only have 3 codes. 97802 to 97804. Non-physician personnel for medical nutritional therapy assessment. Codes report face-to-face with a patient based on 15 minutes for reassessment, and then 30 minutes for group assessment. And again, the documentation would indicate the nutritional assessment, prescription recommended to the patient, anything like that would need to be documented for medical necessity. We then have our osteopathic manipulative treatment, OMT, 98925 to 98929. It's done by a DO to eliminate somatic dysfunction and related disorders. The codes are based on body region. You can see there's only 5 codes. Head, cervical, thoracic, lumbar, sacral, pelvic region, lower extremities, upper extremities, rib cage, abdomen, and viscera region. They are divided based on the number of body areas treated. So in your diagnoses, you've got all those that I just listed. So you've got quite a few somatic diagnosis. I think it's M9900 to M9909. I think we have 9 of them. But only 5 procedure codes because it's based on the number of body regions treated. And again, it's done by a doctor of osteopathic medicine. Then you've got 4 chiropractic codes, 98940 to 98943. Again, divided on the number of regions manipulated. So with chiropractic, your spine is divided into 5 regions: cervical, thoracic, lumbar, sacral, and pelvic. And then we have our extra spinal region, also 5 regions: your head, lower extremities, upper extremities, rib cage, and abdomen. So this is manipulating the spinal column and other structures. The professional assessment is bundled into your chiropractic codes, so you can only bill an office visit separate if it's indeed not related to the chiropractic treatment. So you can do this one right from the book, but look at number 2, the osteopathic manipulation, 1 region. Osteopathic, 1 region.
98925.
98925, right, and that's just 1 or 2. And then you'd have that M99, I want to say the head is 03, but good. Non-face-to-face. If you look in your CPT book, we've got 3 codes for non-face-to-face. Telephone services, 98966 to 98968. And we have online medical evaluation, 98969. Again, the telephone is reported based on documented time. Your online is per incident. Again, there are a lot of doctors who will do telephone assessments on patients, especially if they can't get out of the house. Just know that if they're doing the services, we should be reporting them or at least documenting them in the patient's chart. Doesn't necessarily mean that we're going to get reimbursed for them. But obviously, if it's part of the patient's care, it may end up catching up and your physician makes up on it, the next time they come in the office. Special services, procedures, and reports, 99000 to 99091. Miscellaneous codes, unusual hours of the day, holidays. If the physician goes in the office on a Sunday to meet a patient and provide urgent but not emergency service, then we have a code from this section rather than a regular old office visit code that we would use during our regular hours. I wish I could convince my docs to use this because they see patients after 5. We have fractures. They walk in after 5. We could use these codes, but he figures he's already there. You also have the one we've talked about, the 99024, which is your post-operative follow-up visit. This one is used during a global period. There is no reimbursement for this code, but it does allow us to track so we know how many times we've seen that patient during a post-operative period. You have your 99070 code for the supplies. And again, if there is a specific code, we want to use it, because if we do just use our generic code, they may request additional information or an invoice before they process that. This section also has codes for medical testimony, completing reports, education services, unusual travel, and supplies. These would be located under special services. So you can see, I'm not going to do these examples, but conveyance of a specimen from the physician office to a lab. So if your doc is collecting a specimen and you're physically transporting it to the lab, there's a code that you can bill for that. Other services, 99170 to 99199. These may be anogenital exams of a colposcope for a child with suspected trauma, visual function screening, pumping poison from the stomach, maybe some phlebotomy. Some of these codes are based on, again, time. So we want to make sure that if it is time related, we need to document it. And if you look in your CPT book, you've got quite a bit of it. Mine's green, but you've got a lot of notes with regards to the conscious sedation codes in this section, telling you what is considered that intra-service work and the post work. So again, knowing what's in those codes. 99500 to 99602, non-physician services at the patient's residence, which can be assisted living, group homes, anything that's considered the patient's residence. We've got two codes, 99601 and 99602. 99601, and these are home infusion. Administration of a variety of therapies, can be nutrition, chemo, pain management. These are also non-physician. So this would typically be like your home health agencies administering home infusions. We've got 3 medication therapy codes, 99605 to 99607. Patient assessments and interventions by a pharmacist upon request. So this is asking the pharmacist to assist with management of treatment-related medication complications or interactions. And again, these codes are by the pharmacist based on new or established, and again, time. So these codes are only billed by pharmacists, nobody else. And that's it for the medicine section. So the thing to keep in mind is not trying to remember just because it's a 9 code, is it an evaluation and management code or is it a medicine code? You'll get a feel for, typically most of the testing is considered in the medicine section. If it's an office visit or a hospital visit or a preventative yearly exam, those are typically going to be your E&M codes. Any questions on the medicine section? Nope.
No.
Okay, 1 chapter left.
Let me write that.
All right, when she comes back, we will do chapter 27.
All right. I'm going to grab some water, then we'll
Yes,
just do that.
absolutely.
There's like a hallway down there, and just goes straight. No, it's
Okay.
just like you just walk up
Sorry about that.
Oh, that's all right. She went to grab some water, so as soon as she comes back, we will finish this chapter.
Oh my goodness.
I couldn't find the fountain, so.
Oh, all right. Well, we won't, this chapter is not as long as it looks, so it shouldn't take us too long. Because you know the basics of coding. So what this is intended is to tell you or let you know what the differences are between inpatient and outpatient coding. So for inpatient, we code what's called the principal diagnosis. So that means the condition that is established after studies or tests. The diagnosis chiefly responsible for patient admission. The selection of inpatient principal diagnosis applies to all non-outpatient settings, so that's acute care, short-term, long-term, psychiatric, hospital, home health, nursing homes. When we select inpatient principal procedure, you know how we use for the outpatient setting, we used our CPT book. When you're coding for the inpatient, you're going to have an ICD-10 book, which you think is your diagnosis, but it's PCS. So it's the procedural coding system for the facility. So if you're coding hospital inpatient, you'll have an ICD-10 diagnosis book, and you'll have an ICD-10 PCS book. So again, outpatient, you've got your CPT, your HCPCS, and your ICD-10. For the facility, you'd have your ICD-10 and then your ICD-10 PCS. If you look on 707 in your textbook, again it says in the inpatient setting, ICD-10 PCS are assigned instead of CPT and HCPCS. Procedures need to be sequenced properly with a principal procedure listed first. Principal procedure is the one performed for definitive treatment rather than diagnostic or exploratory. So again, that's kind of the same as if you go in and look and you find something, you're going to code the definitive for the facility as well. Procedure is considered to be significant if it's surgical, carries a procedural risk and an anesthesia risk, and requires specialized training to be performed. Any procedure affecting reimbursement should be coded and reported. And most of your facilities will have a policy regarding what procedures should be coded. And again, that follows the same as outpatient. There's going to be some procedures that are done as an inpatient that still are going to be ones that cannot be billed together. And that's where we go or refer to our CCI edits. The principal diagnosis, I've already mentioned that, but you can see that on the bottom of 707. So the circumstances of an inpatient admission always govern selection of principal diagnosis. It's the condition established after study to be chiefly responsible for the admission of the patient. So again, this can be different than what we are coding as inpatient. If you look on 708, the principal diagnosis is sequenced first in inpatient coding. In an outpatient setting, the term first listed condition is used instead of principal diagnosis. It is used to indicate the main reason for the visit, and then additional diagnoses can be used to substantiate other services such as lab and x-ray. Principal diagnosis refers only to acute care settings, so only hospital. First listed diagnosis is outpatient setting. So here for the hospital, code for symptoms, signed, and ill-defined conditions are not to be used as a principal diagnosis when a related definitive diagnosis has been established. So here we don't use for inpatient, we're not going to use signs and symptoms. They should have a definitive diagnosis that we can use. On 709, if there's 2 or more interrelated conditions, when there's 2 or more, potentially meeting the definition of a principal diagnosis, either condition may be sequenced first unless the circumstances of the admission or the therapy provided or your alphabetical index or tabular tells you otherwise. Meaning, let's say there is 2 different diagnoses. Either one could be first, but when we go look it up, one of them is italicized. You guys remember italicized can't go first. So therefore, that's going to be the reason we're not going to list that one first. Otherwise, if there's no italicized or it doesn't say code first or C also, it doesn't matter what order you put them in. On page 710, if 2 or more diagnoses is equally responsible for the outpatient visit, either can be sequenced as principal diagnosis. That is the same for inpatient. So 2 or more diagnoses equally responsible for the visit, they can be, either one can be coded first. And the thing to remember is these guidelines, if you were coding inpatient, those guidelines are in that ICD-10 PCS book, so you always have those to refer to. On page 711, comparative or contrasting conditions. So sometimes we're going to have 2 or more contrasting diagnoses that say either or. They are coded as if the diagnosis was confirmed. So that is not like what we have in the outpatient setting. Okay, we can't code them as if they are confirmed if they weren't confirmed. Okay, so that's another difference with inpatient. On 712, original treatment plan not carried out. Sequence as the principal diagnosis the condition which after study occasioned the admission to the hospital, even though the treatment may not have been carried out. So in this case, it was the reason, the diagnosis for the condition, not obviously what they found, because they didn't find anything because it wasn't carried out. So the reason that they typically presented. If there's complications of surgery, when the admission or is for treatment of a complication, the complication code is sequence principal. If the complication is in the T80 to T88 and it lacks specificity, then we can use an additional code. So there's not a lot of differences between inpatient and outpatient, but again, just a few. 714, this is the big one here. For inpatient, if your diagnosis documented at the time of discharge is probable, suspected, likely, questionable, possible, still to be ruled out, you code the condition as if it existed or was established. This guideline only applicable to inpatient admissions for short-term, acute, long-term, and psychiatric. So that is not how we code as outpatient. Okay, we don't code it as if it's there. We code our signs and symptoms. So that's a big.
None of this is on the test, right?
No.
Okay.
It's just letting you know what the
Okay.
are. Yep. Hospitals are reimbursed as a set payment with regards to Medicare severity DRGs. So they're reimbursed depending on their groups of diagnoses. So that's a different way than outpatient. We're not reimbursed based on group diagnoses. If you look on 715 for a patient admitted from observation, when a patient admitted to observation for a medical condition and it either worsens or does not improve, and they are admitted as an inpatient for the same medical condition, the primary diagnosis would be the medical condition which led to the admission. If they are admitted following a post-operative observation, then they apply the principal diagnosis, the condition established after study, to be chiefly responsible. So if they're post-surgery, it's typically whatever they found on the surgery, if it was a bleeding ulcer or whatever it happens to be. 716, admission from outpatient surgery. The guidelines should be followed again for principal diagnosis. If the reason for inpatient admission is a complication, we assign the complication. If no complication or condition is documented as reason for inpatient admission, assign reason for the outpatient surgery. So they've had their outpatient surgery and now they're being admitted. We don't have a reason they're being admitted. So we use the diagnosis from the surgery. If the reason for the inpatient admission is another condition unrelated to the surgery, then that unrelated condition. So they had surgery for gallstones and they're being admitted because they had chest pain. We're going to code the chest pain, not the gallstones. Reporting additional diagnoses. Again, additional diagnoses have potential to affect reimbursement. So we want to make sure to capture those conditions. And again, for inpatient, you can see clinical eval, therapeutic, diagnostic, extended length of hospital stay, or increased nursing care and or monitoring. If the conditions all existed and all of those conditions played a role in how long the patient stayed in the hospital or why they were in ICU, then we want to make sure we nab all those diagnoses because that's going to support the medical necessity for them being in ICU. If you look at the bottom of 717, again, additional diagnoses, previous conditions. If the provider has included a diagnosis in the final statement, such as the discharge summary or the face sheet, it should ordinarily be coded. Some conditions will not be reported. It depends on the hospital policy, and it tells us history codes history codes can be used as secondary codes if it has an impact on the patient's care. If the patient was there for breast cancer, then it would be okay to use a history code if there was a family history of breast cancer. But if there was, if there's that family history doesn't tie into the patient's condition, then we're not going to use that Z code in the hospital setting. Abnormal findings on 718. Labs, x-rays, path, other tests are not coded and reported unless the provider indicates their significance. If the findings are outside normal range and they've ordered other tests to evaluate, it's appropriate to ask whether we should put the abnormal finding or possibly use a signs and symptoms instead. But there is a diagnosis code for abnormal findings. Uncertain diagnosis, 719, again, we just went over that. But if they are, again, an inpatient, they can use probable, question of, rule out, whereas we cannot. Present on admission, POA. Again, because hospitals are reimbursed under those diagnosis categories that are present at the time of a patient's admission, There was a policy in 2007 that was administered that said CMS will not pay for conditions considered preventable, such as pressure ulcers, falls resulting in injury, infections of the GI or central line catheters, or complications occurring during hospitalization. So therefore, there is a present on admission indicator that will distinguish whether the conditions developed during a hospital stay or if those conditions were present at the time of admission. So again, that's important for the facilities to be reimbursed. Because if it's present on admission and it was an infection, they'll pay for that. If it was a result of something that was done in the hospital, they're not going to pay for that. The last thing we need to talk about with regards to the hospital, again, everything's looked up the same way. So even with the ICD-10 PCS, they still have an alphabetical index that leads them to the tabular numerical. But this is how the ICD-10 PCS is set up. It is considered volume 3 of the, it was volume 3 of the ICD-9. But again, ICD-9 did not have specificity. So therefore, we changed to ICD-10, and CMS contracted with 3M Health, and they are the ones that put together the inpatient coding procedures. So there are 4 objectives of the PCS: completeness. So there is a unique code for all substantially different procedures. Previously, procedures performed on different body parts using different approaches were sometimes assigned the same code. So now there's more specificity for the hospital side. Also, we have the expandability. So as new procedures are developed, we have the ability to incorporate those new procedures, whereas before, that's why they were coded according to body part, because there was no room to add any more procedures. Multi-axial, more than one part. So the PCS should have a structure such that each code character has, as much as possible, the same meaning. And then again, standardized terminology. So in our, every day, sometimes a word can vary in usage, but in PCS, they are assigned a specific meaning. So if you take a quick peek on page 720, here's how ICD-10, the PCS, is set up. It's set up in 7 characters, and if you look on page 721, you will see that for medical and surgical procedures, the first one is the body section, and then the system, and then what was done, the root operation, the specific body part, the approach, the device, and then a qualifier. If it's with regards to radiology, still the section, body system, root type, body part, then we've got contrast qualifier, and qualifier. So your character 1 is the section. And if you look at the bottom of page 720, here are your sections. So 1 is obstetric, 2 is placement, 3 administration, and so forth. And there are some letters. So if you were inpatient and you're coding obstetrics, your first character is going to be a 1. And then characters 2 through 7 have a standard meaning with each section, but different across sections. So again, the meaning of the 7 characters for imaging are different than those for surgical. Each code has to obtain 7 characters. If there is not an applicable character, the letter Z is assigned. Now, in the outpatient for ICD-10, if there's no applicable digit, we use the letter X. But for the hospital PCS, it is Z. So 2 is the body system. 3, again, is the root operation. And that holds true except for radiation, rehabilitation, and mental health. if you look on page 723, again, your index. There is an index and a tabular list. Again, broken up by body system, body part, what was done, maybe what was used. And again, sometimes it's playing with what word you look up. So hysterectomy, it might say C resection, female reproductive system. Some people could start with, uterus removal. So again, the same type of scenario, but still looking up. X-rays. In the PCS, it says C imaging. Now, some of the X-rays that are done in the CPT book, you can actually find under the word X-ray. Some of them might say C radiology, something else. But again, the basics are there. You can see the tabular list is the same. You've got your main word, and then it's broken down by body part. But look at the different layout of the codes. I mean, our CPT codes is 5 digits. Here, we've got alpha numeric. So again, that's another main difference with the hospital coding. That pretty much is the big thing between hospital inpatient coding and outpatient coding is principal diagnosis versus the first listed diagnosis, being able to code probable, question, rule out, and then that they use ICD-10 PCS instead of CPT. Other than that, you're still looking up everything the same way. Now you can see through the rest of this chapter, it's just table 27.1, and it just goes over the root operations. That's your second, no, not your second, your third, third character. So if it's an alteration, it tells you you're modifying the structure. If it's control, you're stopping something, creation. So again, just a lot of terminology for what those root operations are. Removing a device, you're taking it out. So a lot of it's common sense. But if there's any of those medical terms like extirpation, that means taking it or cutting it out. I wouldn't have known that. I mean, I know removal means taking it out, but extirpation. So if there's any of those unusual words, remember, anything you want written down in any of your books, you can write, but don't put them on sticky notes. Just write them on blank pages. But no, you will not have any questions with regards to inpatient on the test. We just want you to know the difference. You may see, you wouldn't have a question with regarding coding, but you may see a question that says, if you were coding for inpatient, what coding manuals do you use? And you'd be looking for ICD-10 PCS instead of the one that the office uses. Something like that, but not coding questions.
If somebody does wants to do that kind of coding, there's a separate test for it, I imagine?
They still take the CPC exam, but then if they are coding inpatient hospital all the time, then yes, there is, I think it's through, their certification is actually through AHIMA that certifies them for the hospital aspect of it. The coding aspect is the same no matter whether you code for inpatient or outpatient. It's just the group that sponsors the facility side of it. Mm-hmm. But other than that, that is it. You guys made it through all 27 chapters.